in Texas that they were set to lose from the federal government in the absence of the waiver. And that's what I heard. And again, I might have heard you not quite right, but here's my question. To be able to say a number, whether it was 2.9 million, 29 billion, or 290 billion, the number's not important. What's important is if I was to go ask 100 people in the Texas state legislature, would they nod along that 29 billion number is roughly the number? Because here, we're not of one mind in this task force. And what I'm seeking to understand along with Representative Meeks is, what, where, and how can you align us to, at least what the facts are, or the closest things to the facts, like uncompensated care.
And let me clarify that. The impetus for that application for that District 1115 waiver was the loss of uncompensated care funding. The $29 billion was what HHSC was able to negotiate with CMS. So the $29 billion is not just a reflection of the uncompensated care that we were losing. It was actually above what the state estimated it would be losing. And again, those are all estimates, based on future projections. But I would just say it was a very, very successful negotiation. And there have been other states that have been, this is publicly known, quite envious of how successful Texas was. But I understand your concern. You've got different perspectives. You're coming from different places. You've got different constituents. You've got a lot of stakeholders who are coming to you, I'm quite sure, explaining their position, and they're all valid. None of them should be dismissed or not taken into account. All we can do is provide you with a balanced approach that's objective, that is validated, that is substantiated with the numbers of the analysis that we're doing, and provide you with the scenarios and our best recommendations. Does it mean that we think everyone is going to jump on the wagon and say that's a great idea? We understand that this is a process of negotiation. Which is another reason why we think the midterm report is important. We hope to be able to raise some of those issues at that point, hear what your perspectives are, get your input, and then take those into account as we develop the final recommendations.
Thank you. Thank you, Representative Meeks, for letting me interrupt you. And if you have a follow-up, please go ahead.
I have one follow-up question. And of course, you referenced the connections that you have with Arkansas already. And while that can be a strength as far as knowing how Arkansas works and being familiar with a little bit with our Medicaid program, that to me it's also can be a weakness as well, because the task force is trying to get a big picture, something that maybe has never been done before in the country. And my question is how can we make sure that the integrity of what we're getting is going to be good if if the solution that we're looking at has a negative impact on a contract or what you're already doing in Arkansas. In other words, how can you remain unbiased with what you're doing if you see that what we're doing as a task force may have a negative impact on some of the contracts that you currently have in the state of Arkansas?
With the University of Arkansas, did you say?
Well, I know you're working with UMS, but you listed Arkansas in your references back here.
Yes.
And I'm not sure what contract you already have with our Medicaid system.
Oh, okay. Those of all were in the past. As I mentioned, the last one expired, I believe, in 2012. So we have no ongoing contracts with Arkansas right now.
Okay, so you're free and clear of their.
Yes.
Okay, thank you.
Yes.
All right, thank you, Mr. Chair.
Representative Murdoch, you're recognized for a question.
Thank you, Chairman, and thank you for your presentation. Representative Meeks and Chairman Collins go down the same road that I want to walk down just a little bit and answer the question. And that question has something to do with integrity of what your firm, if chosen, will actually report back. As you can see, you can actually do something to provide a recommendation, direction to some degree for a group of people that have been brought together under the guises that there needs to be change. Some believe change as if necessary, and some believe change anyway is necessary. What we'll be depending upon, or what I will be as a task force member, is hoping that whoever the consultant that assists will have the wherewithal to provide an accurate and unbiased opinion simply purely based upon what the findings are. As part of your presentation, you talk of an audit, and that audit obviously is going to be limited because, as you stated earlier, to truly audit this huge program, you don't have the time, nor do we have the money to fund such a performance. So there's going to be some reliability on existing data to some degree, which is expected. But again, when you get back to us 16, that probably, as you can already hear, maybe think differently about some of the things we've been told about uncompensated care, the many definitions for that. My point being, will you be able to, do you feel that your firm will be able to provide an unbiased decision even when it says no change is necessary? You know, will you be able to say in light of who you're talking to that what you have, after we've audited, we've looked at it, this works pretty good. Now, your first bullet point says there's no perfect solution. Well, there's no perfect solution, then it leads to the point of priority of solution. There's no perfect, so there's a priority. Now, how will your priority be developed? Will it be based upon this factor or that factor, or this belief or that belief, or ideology? What we want, all 16 of us, I think, is we want to know what is best. We want to know what we can improve. We even want to know, I think most of us, if what we're doing is okay. All of those things are important from a consultant, that they can stand purely on their own 2 feet and provide us an integral set of direction and guidance that will truly help us make a good decision as we go forward. Do you think that you'll be able to provide that? And if so, how do you, because I don't know if you've ever done this before, but how can you make that happen in this dynamic? Because it's a pretty strong current both ways.
Absolutely, and you know, there's a lot of attention on Arkansas. Everyone is looking to see what you do. This is kind of a game changer. I would just tell you, you know, as I've reiterated a couple of times, we have a lot of different clients. If we were, we have no, regardless of what our recommendations are from our client base, and not here in Arkansas specifically, but you know, whether it's hospitals or health plans or providers or financial investors, there are going to be winners and losers. Some people are going to like recommendations, some of them. They may like part of them, and they may not like others. That plays absolutely no role whatsoever in our analysis. We don't think like that. We look at the policy, you look at the state, the dynamics, the programs that you have. We look at the data, the results, and then we use our knowledge, our experience to develop the strategy that we think is going to work. It's not about who's going to gain, who's going to be a winner, who's going to be a loser. It's about what's going to work and does it meet your goals and objectives. It's not, we truly have no vested interest in directing this project one way or the other, none whatsoever. So I hope that answers your question.
Thank you. Yes.
Senator Kirby recognized.
Thank you. I'm over here. Okay, okay. Thank you. I just 2 quick questions. And one of the things that you talked about is, you know, it is continually evolving. Healthcare is continually evolving, and so, and we have an executive branch kind of view of things, but we also have a legislative branch view of things, and that is cost. I think you have to find a balance in cost versus care. And so I'm interested in, you know, how you would find that balance in, and will you as a firm, be looking at that within your policy decisions. I mean, stakeholders are important because we represent those people. We represent the care that's being given to patients. We represent the patients, we represent the providers, we represent all those within our districts. And so that's going to be key, I think, for me, listening. And so, because what I feel is you could be heavy on the executive branch versus legislative branch, and there's got to be a balance there. And so I'm interested to see, because I think I'm not interested in a regurgitation, I think, of all the healthcare reform buzzwords. There's a lot of them out there. And what Arkansas has done, whether you agree with it or not, and I've been one that agrees with some of it and disagrees with some of it, it's innovative. It's innovative. And I'm interested in innovation and not in regurgitation. Because I do read medical journals. I do read all those different things as well. So how would you respond to that? And will your data that you're looking at reflect all of that? Will you be fully integrated into Arkansas, into all the corners of the state, and really understand the dynamics and how diverse the state is when looking at that policy recommendation?
Well, it is certainly our intent that we would look at dynamics of your population, whether it's rural and urban, or if it's your population demographics with your elderly, your young, the income variables of the people that you're trying to serve. I think if you cannot focus on either care or cost exclusively, or you're going to fail at whatever you're doing. They have to be integrated. If you are not addressing the delivery of care, access to care, you may look good on paper in terms of saving costs, but in reality, the long-term result is going to be more cost. You cannot ignore one or the other. They have to be interrelated. You have to demonstrate how your cost analysis is both objective, that you have to look at the impact on the population that's going to be served. And you may develop ideas when we do the modeling. You may have some things that look great when you first run the numbers, but when you start adding in some of those other variables, like the population demographics, the age, the utilization rates, and the data that would be considered in that development, and you realize, well, we've just cut a benefit out of here that is extremely valuable and necessary to a critical component of the population. By doing that, we're going to save money on this side, but we're going to push it in a different direction so that your costs are going to go up here, and you're not going to save money at all, and your health outcomes are going to suffer. We have physicians at our firm. That's one of the things that they are there for, is to look at the cost, the care component of it, to look at those recommendations, those techniques that look good and sound good, buzzwords, payment reform. We want to make sure that it's actually going to work and not face unexpected, unintended consequences later on. So, we will take all of that into account. It's not about, and to be perfectly honest, I truly understand, the political aspects and the history and the challenges. This is as you said, it's innovative. No one else has tried anything like this. I can't stress again how objective we really are. We look at the information, we look at healthcare delivery system, we look at people that you are going to be serving, the people that are going to be affected by these changes, and what it's going to mean to them when they get sick and they need to go to a doctor. Are you going to be providing the services they need? Because if you're not, they're going to find it somewhere else, and it's going to be more expensive, it's probably going to be delayed, which means the outcomes are not going to be as good, and it's going to lead to other expenses that were avoidable from the very beginning. If you don't address both of those at the same time, you're not going to be successful in the long term.
Thank you. My second question is, are you able to look at the current average cost per beneficiary with any private option? We're paying a premium per month. But then will you be able to look at the money paid out in services and will that information, that financial information, be part of, can that be used as part of a waiver for Medicaid?
It should be, it is something that we intend to look at. Now, that assumes that we can get access to the data. The utilization data, as I understand, is going to be, I'm not sure if it's going to be available to us readily. That's one of the things that we will have to look at because you've got private carriers that possess that information. So we certainly would expect that your contracts probably would require them to provide that information that we would need. Certainly would be our intent to look at it, see when we can get access to it.
And would that be able to, that money be calculated into a waiver?
Yes, it would be part of the analysis.
Thank you.
Representative Henry,
Thank you. Just two quick ones. The issue of the definition of terms like uncompensated care, for example, when you, how soon in the process would you provide the definitions to us as to what you mean by uncompensated care or some of the other hot topic definitions that are going to be critical to move forward with the project and us all being on the same page?
We could do that very early. I mean, if that is something you would want us to vet with you or to provide you with, we would do that very early on because it's going to be part of the analysis. If we can't get those definitions, if you have concerns about the way we're defining them, then we need to resolve those early on.
Okay, and then the
Absolutely.
second, thank you. Then the second thing is, I was looking through, your proposal and the handout today, and in a short way, would you just, we're talking healthcare, but there's a lot more to what we're talking about. We're talking about nursing home costs, we're talking about mental health costs. Real quick, give me a snapshot of your capabilities to blend it all together, not just the healthcare side that seems to be dominating the conversation.
Sure. And again, we have people that do nothing but specialize in long-term care. The dual eligible population who's eligible for Medicaid and Medicare, we've written some of the proposals for those dual immigration projects. We are just now implementing a pilot project in Texas that we did some work on to transform the way we deliver care. Your duals, your long-term care, whether you're getting community-based services or institutional care, those are all part of your cost. There is no question. People in long-term care are getting both medical services as well as housing, basically. Mental health is a critical component of this. Never once thought that it would not be part of the assessment that we're going to be doing and evaluating, both in terms of the recommendations and if you're not addressing your mental health needs, then you're going to have costs on the healthcare side that have to be paid somewhere. So it would always be our intention to include mental health as well.
Great, thank you. I got the picture. Matt, I got just one quick one. Are you going to make a recommendation? You mentioned a tool that does an assessment. For example, somebody comes in and they have multiple needs, and what I understood you say is a tool that would assess that individual and then produce a result on the basis of a analysis, for lack of a better word. Are you going to bring us a recommendation of existing tools that are out there, or are you familiar with the existing tools that are out there that already achieve that, or are we going to be looking at maybe the creation one? Because to me, that's a key component to knowing what the true cost is if Johnny needs multiple services, so you prevent that overlapping. So do you have a new tool, you got existing tools, or you're going to make a recommendation for a tool that we need to look at developing?
That would be part of our review. Probably it would be a hybrid. It would be relying on an existing tool as well as making some modifications if necessary to reflect the different program components and the stuff that's integrated and the stuff that's not. So that is something we would include, definitely.
Thank you, sure. Thank you, Diane. As I kind of look at, really all the things we're asking for this business partner, if you will, to do for us, it's a little bit like, a soccer tournament or a softball tournament where you've got, a couple different teams come for the afternoon, and there's players and coaches and umpires. And it's almost like we need someone that can be a player coach, all the teams, and also umpire all the games. Because when the different teams say to each other, is that a ball or is that a strike, well, we're going to need somebody that's able to earn the confidence of both sides. So when they say, no, that's a ball or that's a strike, people may not like it, but they can accept it as opposed to denying it. So that we can move forward together into this uncharted territory. It feels to me like your cost and capabilities through the October period are ready for that type of a multifaceted, heavy investment role. Beyond the October period, it feels to me, if that's going to continue, and I think to some degree it's going to have to, we're not going to be able to do all the things we're trying to do, without having some extension and phasing and things of that nature, in my view. Would we just need to do a follow-on contract? Or do you think that, embedded in the $750,000 number, it includes doing that up to the 16? I just would be interested in your thoughts on that, so that as we're framing up in our minds, we have a sense for how we need to change that if we do.
Sure. And again, we really tried to follow the intent of the request for proposals that specifically said this scope of work, it outlines the scope of work, and it says that it would culminate with a report that would be due October 1st, followed by a presentation. And it also said that I believe there was even though the contract runs through December of 2016, additional work beyond that scope of work would be compensated. I believe it said up to 10% of the value of the contract. But clearly, I think to the extent you would need our services, we would definitely be available and could certainly do a contract amendment to add for that additional services. And it would continue to offer you the pretty significant discount that we've included in this proposal.
Let me just, I think I've had a couple of people, we just want to clarify this because we want to make sure as we're comparing the different proposals, we're comparing apples to apples. You are comfortable under the proposal that you've made that you can provide the final report and then continue to provide the services that are at the outlines through the end of December and the following year?
Yes, with the addition of, depending on what additional services you would need that are outside the scope of work of this RFP. The contract itself extends, but the additional services, I think we would have to.
Well, obviously, if we task something that would be used outside the scope,
Yes.
I think the scope is also written in a way that, if we have questions that should be able to be answered from the work that you all have done, we would expect those to be presented and provided to the task force.
Oh, absolutely. Yes, absolutely.
All right, thank you very much. That was really most of my question. I did have a concern about whether or not you would be able to continue on to 2017 without a lot more money. But since I've got the microphone, I've had a real concern about small businesses. And I noticed that in your potential areas of focus, you mentioned Healthy Texas, but you said that that was no longer a program that Texas had. Can you tell me why they don't do that anymore, and would that something like that be applicable here in Arkansas?
The only reason it was discontinued was because of the Affordable Care Act and the reforms to the small group market. The expectation was that because that program was specifically designed for employees making 300 or less % of poverty level, although there were 60% of the employees had to be at that level of the employer. The expectation was that those individuals would qualify for subsidies in the individual market and would choose to probably purchase that coverage over the small business. So it was the decision of the legislature to discontinue that program and allow the market to kind of play out. There have been discussions about possibly reinventing that, again, specifically because we still have so many small businesses who are uninsured, or their workers, they don't offer coverage and their workers are uninsured. Even with the subsidies, small business coverage is expensive, and that may, over time evolve to where it becomes more affordable and we see a higher take-up rate. We still, of course, we don't have the expansion option in Texas, so we still have, but we're, we know we're have the highest uninsured rate in the country. That's nothing new. It's not something that we're proud of, and that, there have been a lot of attempts to try and address it. That was a very successful program by anyone's analysis. No one has denied that. I definitely think it was something that we would want to evaluate for Arkansas to consider.
All right, thank you.
Dr. Bledsoe, you're recognized. Mr. Gilbert, please.
Thank you, Mr. Chair. So I just have a quick question, and this is piggybacking off of the question that Representative Hammer had and Senator Bledsoe and Senator Hendon. One of our biggest concerns is that we're going to get to the end of this, we're going to have a report at the end of this year, and then going forward in 2016, we might or might not have the support that we need to finish this out. Looking at your travel expenses, I see that you have $35,000 allocated for travel. What percentage of that has been set aside for possible travel expenses in 2016? In my mind, it's one thing to have access to your consultants via phone or email, but if we need you here in the state in 2016, do you have allocated budgeting costs for that?
Well, the way we interpret the RFP is that it was just a maximum $35,000 for travel, so that's what we put in here. We even submitted some questions trying to get some clarification about that, and we're basically, the response was to read the RFP. So we kind of interpreted it to mean that we should go ahead and put in the maximum. Our actual travel costs, based on the number of trips that we thought we would need to take, came in at about 19 or 20,000. So there is an additional $10,000 in there. I think that, assuming we were pretty accurate on our estimate of cost, we're pretty conservative too. We stayed at, not the cheapest hotel, certainly not grand hotels. We take cheap flights and we eat at cheap restaurants. So we're very cognizant, again, of the fact that this is taxpayers' money, and the fact that so many of us spent our careers in public service. We are respectful of that need to contain cost in the travel expenses.
Can I ask a follow-up question? So of the 19 or 20,000 that you estimated would be associated with travel costs, how many trips did you think that would be for your team?
Oh, I'm trying to remember. And we had, the costs were different depending on where the people were coming from.
Sure.
The flights were different. And we also assumed that, we would be scheduling those events so that we weren't buying last-minute airline tickets and things like that. But, I want to say it was like 16 trips of various people.
As individuals?
Average cost per trip. I want to say it was somewhere around $800.
So in other words, $10,000 wouldn't be one trip or two trips.
Okay.
If you set aside $10,000, that would be multiple trips
Yes,
in 2016.
absolutely.
Okay,
Yes.
that's what I wanted to know. Thank you.
Okay, Bill, I've got a couple of them in Hammer, and that's all that's on the list, and that'll work out about right for lunch, unless somebody has something, we'll take a couple more quick ones. Just real quick, I want to ask a question based on some of the things that you made in the presentation. The first one is a statement, and I've heard this statistic before, that 10% of the people take up 70% of the cost. My question is that a generic statistic applied to the traditional Medicaid program, or is that a statistic that you have some supporting information that it's also true of the expansion population?
It's more of a generic, it's not applied specifically to your expansion population. Ideally, I mean, I would expect that many of those people are younger, relatively healthy. They're usually, individuals who either don't have jobs that offer insurance or the daredevils who don't think insurance is important to them. And so, as a
It's probably
whole,
more geared towards the traditional Medicaid. And I guess that's part of the members' benefit. Our next hearing is going to focus some on trying to get a grasp of what the cost drivers are in the expansion population, because it is a significantly different group of people than the traditional Medicaid program. And some of those ideas may be completely different, but we don't know because we haven't got the data.
well, and you also have that pent-up demand everyone talks about when you're people who previously did not have access to health insurance or health care, haven't seen a doctor in 3 years, and so they're going to go to the doctor and get the test. But you should see that level off definitely certainly after the first year.
Senator Bledsoe asked the next question I have, but I just want to get a little clarification on it. It has to do with Texas's motivation to terminate their small business program that they put in place. And I guess, is it true that that is primarily because of the availability of subsidized plans on the exchange, that they did not see that they wanted to compete with that program through the Affordable Care Act?
Yes, that is true.
And then the final question I have is, can you, in the several slides, you talk about the experience and the projects and different things. If you had to point to one specific recommendation or proposal change or program change that you all were instrumental in that demonstrably lowered the cost of the program while still maintaining the healthcare quality, what would that be?
I would probably say it's the integration of behavioral and primary health care, because unmet needs on the mental health side is such a huge issue, and it's such a huge cost driver. And that's true anywhere you go. We have, through the district projects, through many of the waivers that we worked on, that has been a fundamental problem in virtually every state that we have worked on, and something that they all struggle with. And the results can be incredible. You've got a lot of people, whether they're using their corrections, they're going to jail because they have mental health episodes that aren't treated. You have people who don't have housing, who are literally using the jail as a place to live. It's not just your healthcare system, but it's so many other areas of your government infrastructure, both at the local level and the state level. So if you can address the mental health care needs, you are going to see significant savings on the physical health care side, because that's where people are getting those services. They're not going to get psychiatric care, they're going to the ERs, they're showing up in the jail, and it's just, for a lot of complicated reasons, those services aren't being provided.
Okay.